Hello, my name is Eilis Hennessy. In the video presentation that you're about to watch, I present a seminar to the UCD School of Psychology in which I talk about my research on stigma and youth mental health. The talk is entitled Stigma and Youth Mental Health, the Importance of Social Context. And in the talk, I argue that it's very important to understand the kinds of experiences that young people with mental health problems are likely to face in their peer group and in the wider community. And I argue that we need to study the way in which people respond to young people with mental health problems in order to fully appreciate the experiences that they are likely to have. So, good afternoon everybody, and you're very welcome to the first of the year's monthly talks in the School of Psychology. My name is Eilis Hennessy, and the title of my talk for this lunchtime is Stigma and Youth Mental Health, the Importance of Social Context. While I'm doing the presenting today, what I'm presenting is part of a body of work by a large number of my colleagues and collaborators, and you'll see their names appear in many of the studies that come up over the slides which follow. I'm going to start by giving you some quotations from a series of interviews done by Lynn McCaig, one of my graduate students. And Lynn asked young people who had diagnosed mental health problems about their experiences with their peer group and in other aspects of their lives. So you'll see here the first person, Leah. Leah says, "My friend told me that she thinks that people who go to get help for a mental health problem are kind of weird." Gavin told us that there was one person that found out about his ADHD and they kept mocking him because of it. So here are two participants who reported having quite negative experiences of other people finding out that they had a mental health problem. Here are two experiences from young people about interacting with teachers. So the first here is Ella, and she goes, "Stop, that's nothing you can blame your ADHD on." And she said it in front of the whole class, and I hadn't even told anyone. That was my first week in school. I couldn't stop crying. And Melissa, who said, "I think teachers don't think I'm capable of doing things myself." Again, two very negative experiences within a classroom context. Now, of course, these are exceptional. Not all students are going to have this kind of problem. They're not all going to have their peers or their teachers say such awful things to them. However, the fear that something like that will happen is actually quite pervasive. So here are two of the much more common type of statements that young people made to Lynn in those interviews. So Marie said, "I wouldn't want to be made out to be like a nutter," as people like to put it these days. Again, she's talking there about her concern about telling people she had ADHD. Fiona said, "If I told them, they'd probably think I'm weird or something, or that I'm insane or something, because they're really ignorant." So here we see that something that has really nothing to do with having a mental health problem is nonetheless having a very significant impact on these young people. Either they have themselves experienced something negative that is said to them, or else they have the fear that if they tell anybody that people will react negatively. Now, the prospect of negative responses to having a mental health problem is actually extremely widely acknowledged within the adult mental health research work. So much so that in 1999, the Surgeon General of the United States said that stigma was the most important problem facing the entire mental health field. So more so than the treatment of people, it was the fact that people who had mental health problems were being treated differently and more negatively than other people were. And we now have a very substantial body of literature on stigma in adult mental health patients. So, for example, people like Pat Corrigan, Stephen Hinshaw, Joe Phelan, Bruce Link, all of whom very eminent researchers who do very high quality, high level research, and whose work really is beginning to make an impact on the way in which people with mental health problems are treated. However, Stigma is really under-researched in the area of childhood mental health problems, and indeed it's only fairly recently that the word stigma has been associated with that area of research at all. And that's surprising because, in fact, we've known for a very long time that young people with mental health problems have difficulty with their peer relationships. So here, the first study here cited by Bagwell, I mean, this is one of many studies, and I'm sure many of you here are familiar with the idea that lots of kids, particularly those with externalizing problems, find themselves rejected by their peers or else not having really good reciprocated relationships. Just last week or the week before, I was at one of the most recent conferences from the Growing Up in Ireland study, and there they looked, one of the papers at that conference looked at the information that was provided about whether the young person, the 9-year-old, had a mental health problem or not, whether they phrased it as an emotional or a behavioural problem, and where that box was ticked, the children were far more likely to report that they had been bullied by their peers. So that's their own report of having been bullied and their mother's report that they had been bullied. So, why do young people with mental health problems have this difficulty with their peer relationships? Well, is it because of how they behave? Well, to a certain extent, undoubtedly it is. Particularly those who've got externalizing problems, we know very well that they're likely to have a whole range of deficits in relation to the peer group. So I've just put 2 studies up here. There are many more. So the first one, kids with ADHD have incompetent strategies for entering into peer activities. So they're less likely to know how to break into a group or to make friends with a new group of people. So yes, there are problems that are part of the mental health issues that these young people have. However, we know that there is something else going on there. So, for example, there is substantial evidence that changing the behaviour of someone who's got an externalizing problem like ADHD does not in and of itself guarantee that they will become accepted within their peer group. We know that children who are rejected within one peer group may be accepted within another. So everybody knows that from knowing kids themselves or having been a kid. You know, you've one group of people that you get on with, another group that you don't. That says something about that group as much as it does about you. And so the same is true for kids who've got mental health problems. They may get on with one group and not with another, demonstrating that it's not all about their behaviour. There's also a much smaller quantity of research demonstrating that simply labelling a child as having a mental health problem, even if they don't, is going to result in them having more negative responses from other children. So, does that mean that young people are being stigmatised in the way that adults with mental health problems are? Well, to answer that question, we have to look at what stigma is. So there's a reasonable consensus as to what stigma involves. So it's typically seen as having 4 components. The notion of a stereotype, so that is a belief that all people with this mental health problem have something in common with one another, some negative characteristic. It is a negative feeling that goes with that stereotype, so being fearful or angry about that. It's discrimination, which is treating the person differently. And then, in addition, typically within the adult literature, they speak about the loss of power and status. So the idea that to be diagnosed as having a mental health problem would mean that you would somehow be seen as of a lower status within society. Now, this is the one aspect of stigma that I won't be talking about now, because in fact, looking at issues of power and status in children and adolescents is actually quite difficult because of their nature. They are, children and adolescents tend to have low power and relatively low status within society. So there are issues that need to be dealt with there, but I'm simply not going to talk about them this afternoon. I'm going to talk about stereotype, prejudice and discrimination. Well, what might that mean What might stereotypes mean in relation to children with mental health problems? Well, you've already seen in one of the quotations that a child heard someone say that if you went for treatment for a mental health problem, that you would be weird. A stereotype might also involve saying that someone could change their behaviour if they just tried hard enough. It might be believing that someone who's depressed is just a boring person, that they're not worth inviting along to something because they wouldn't contribute. It might, at the extreme end of things, mean believing that someone is dangerous. Prejudice could mean any one of a range of emotional responses. It might mean fear, it might mean frustration, it might even feel anger towards an individual. And discrimination might mean excluding the person, not hanging out with them, not inviting them to a party, maybe even not even wanting to be seen with them. So, what evidence do we have that young people with mental health problems might experience those very things, that kind of prejudice and discrimination from their peers? Well, the research that we've done has mostly focused on young people who don't have mental health problems and how they respond to vignettes or stories about young people who do. So, one of the first of the studies like this that we did was a reasonably large multivariate study in which we looked at responses to peers with either ADHD or depression. And this was not a test of a full model of stigma. However, there were elements of stigmatizing responses in the type of questionnaire data that we collected. And our research suggested that indeed we did find that a stereotype, such as a belief in a higher level responsibility, was associated with lower level of acceptance of a peer with ADHD. So, in other words, the more you believed that someone with ADHD was responsible, the more you believed that they were not socially acceptable and that you did not want to have anything to do with them. More recently, we've done, with Claire Driscoll and Caroline Heary in Galway, we did a much more complete test of a stigma model in which we looked at aspects of stereotype, prejudice and discrimination, and we compared responses to a character in a story who had ADHD, a character who had depression, and a character who has what we call normal issues, so being described as a fairly normal person who fell out with people and experienced the blues in a normal sort of a way but wasn't clinically diagnosed. And again, we found evidence that within this large sample of kids between 10 and 16 that they had much higher perceptions of dangerousness, responses of fear and of anger to people with ADHD and depression. They said that they would have fewer positive behavioural intentions towards them, and they expressed a desire for greater social distance, suggesting that many of the elements that we've spoken about in relation to stigma were evident in their reactions. However, it's very important to say that these were not monolithic type reactions. It wasn't that all kids felt exactly the same way about all of the stories in the vignettes that we gave them. So we found substantial variation based on age. So in Claire Driscoll's work, the adolescents were in fact much less accepting than the younger children who were at the top end of primary school. We found both in Lorraine Swords and in Claire Driscoll's research that there were gender differences. So, for example, in Lorraine Swords' work, females were generally more accepting of both peers with ADHD and depression than were their male counterparts. And in Claire Driscoll's work, she found that males believed that their peers were generally more responsible for the problem. So that was either the ADHD or depression. There was also variation based on the type of mental health problem. So normally we have contrasted depression and ADHD. That's because we're looking for one behaviour that's internalizing and one externalizing. They are common problems, and also one is more common in younger children and one in adolescents. So Claire Driscoll's work found that ADHD was more explicitly stigmatized than depression, and also that that male adolescents attitudes towards depression were far more negative than the comparable implicit attitudes towards ADHD. So again, their responses varied by type of mental health problem, suggesting that in order to know how likely someone is to be stigmatized, you need to know what the presenting mental health problem is. So to us, this meant that we really needed to have a developmental model of stigma. We needed to find a way to try to understand the many variables that might be influencing the development of stigmatizing attitudes towards someone with a mental health problem. Now, clearly there are adult stigma theories. Unfortunately, these are not as useful to you if you are working with children. So there are obvious social, emotional and cognitive differences between children and adults, and indeed between children of different ages. So it's very important that we have a theoretical model that allows those to be taken into account. Clearly, the context of stigma is very different in adults and in children. So for adults, the vast majority of the work on stigma has focused on concerns around employment prospects and accommodation rights. Within children, those are two things that are not particularly relevant at all. We're much more likely to see relevance in terms of inclusion within peer activities, and really crucially for a lot of the young people we've interviewed, a sense of not wanting to be made to feel that they are different. And then there are different types of stereotypical and prejudicial responses depending on the age of the child and the adult. So we needed something that could take those into account. So we decided that instead of turning to the adult stigma and mental health literature, we would instead look at to social psychology, where there's a very long tradition of having developmental models looking at the development of prejudice towards, particularly towards different racial groups. And that we thought would be a potentially useful place for us to turn. Bearing that in mind and looking at the literature on racial prejudice, this really re-emphasised for us the importance of taking a developmental view on mental health stigma, because the racial prejudice literature suggests that prejudice is developed very early in life, and therefore if you're going to intervene, it's important to intervene early. So since last year only, we have been looking at developmental intergroup theory proposed by Bigler and Lieben. Now, apologies, this is a complex model. I'm just going to say a few words about it without going into it in any detail. What Bigler and Lieben here propose is a theory that brings together some of Tajfeld's work, but also some of the Piagetian work. So it's bringing together intergroup theories and cognitive developmental theories. Essentially, what they're saying is that prejudice must begin with the young child learning to categorize people along a particular dimension. So most of Bigler and Lieben's work has been done on race, so that would be learning to categorize people based on racial differences between them. Now, clearly, from very early on in life, it's almost certain that babies pick up on the colour of your skin, but they're picking up on all sorts of other differences between people as well. So really it's not as much about the actual perceptual discrimination as it is about finding out which of the multiple differences that exist between people are the ones that society really seems to focus on. So we could, within this room, classify people on their hair colour, on their height, on the size of their nose, on the size of their feet, but we've chosen not to do that, or not to emphasise it as a society. So it's as much about finding out, the child finding out what within society is regarded as significant, and then themselves doing that classification. So according to their theory, the first part of learning is this early establishing salience, and then the middle section of this model is all simply about the point of view of classification. So in other words, once you make this classification, you now begin to see the world in those terms. So you see people immediately as being male versus female, black versus white, Asian versus European, or whatever. Once that has happened, then it's possible, other than that is when children will begin to pick up society's views on these different groups. And there are a variety of mechanisms by which that might happen. So what we're now hoping to do is to begin to use this as a model that will guide us in where our research should be focusing, and on how it is that we should be designing studies in order to capture the salient elements of the development of prejudice in this way. And what I want to do now is just give you some examples, drawing somewhat from our own research, but also from some other studies, of things that make it look as if this may well be a very fruitful model or theory for us to use in our research on stigma and mental health. But it is important, of course, to point out that racial prejudice is not the same thing as mental health stigma. Firstly, because mental health problems are not marked out by appearance, or they're typically not, as racial groups typically are. So there may be issues around the way in which children learn about these. Whatever race you're born, you're going to be that for the rest of your life. If you have a mental health problem, hopefully on the main, that's a temporary thing. So mental health problems are temporary, not permanent. That almost certainly has implications for how we apply this model. Typically, the model, when applied to racial groups, has assumed that to treat one group of people differently from another group of people is not appropriate. So we do not think it appropriate to offer favours to groups of boys in a classroom and not to groups of girls. However, that's not necessarily going to be the case for mental health problems. It may well be necessary and appropriate for one group of children to have additional coaching, additional teaching, to be let out of class, to go to CAMS or to meet a school counsellor or something like that. So again, that is a difference. Perhaps a more positive difference is that we know that there is something significantly different about the people who stigmatise those who have mental health problems, and that this means that the mental health stigma is very important to tackle. And that is that young people who stigmatise those who've got mental health problems have been demonstrated in multiple studies to be far less likely to seek help themselves if they are experiencing difficulty in their own lives. Now that's perfectly logical, I think. If you think you don't want that these other people are weird or they're dangerous, then you do not want yourself to be classified as one of them. So there's a logical sense there, but it also means that by tackling mental health stigma, you are actually helping not just those individuals who are stigmatized, but also the people who are doing the stigmatizing. So what evidence do we have that there is a possibility of applying Bigler and Lieben's model to our own work? Well, one of the ways in which Bigler and Lieben propose that psychological salience is established is by establishing the perceptual discriminability of the characteristic. So, for example, the different skin tone, different genders, and so on. Now, we have not yet in any way tried to establish the age at which children are noticing these differences. However, we know, because we've done research with 8-year-olds, that by the age of 8, children are well able to give different reasons why they believe different mental health problems might have arisen. Now, for us, that is a clear marker that in some way they are seeing these mental health problems as different from typical behaviour, and indeed different from one another. So this study looked at children as young as 8, and we got them to respond to pretty typically developing peers, as well as peers with ADHD, depression and conduct disorder. This is not one of our studies, but I think it's an important one because there are explicit messages about mental health problems that I think are around us and that you may not register. So this was a very nice study done by Wall and colleagues in 2003, in which they did a content analysis of films released in 2001, 2002 that had a PG or a G, so in other words, they were on general release and largely aimed at families. If you watched the 102 Dalmatians recently. It was back on RTE there a few weeks ago, and I watched it again, always with renewed eyes, having read this, that Cruella de Vil starts that film coming out, or actually within the walls of a psychiatric institution. And as far as I remember, she ends up back in there at the end. The story of the Grinch, in his own narration, the Grinch describes himself as a psycho, and the narrator within the story speaks of his head not being screwed on quite right. In fact, 25%, or almost 25% of all the films that were classified had references to mental health problems. So it is out there, and it is in the kinds of films that are being released for children, not just in the films that are for adult consumption. So children may well be getting messages that the mental health problems and baddies are pretty synonymous with one another. So this is moving to the other side of the model proposed by Bigler and Lieben, and this research finding that we have so far is pointing us to where we might look in future for the way in which children might have exposure to explicit attributions of negative responses towards young people with mental health problems. And this is work that was done by Ruth McIntyre, who recently completed her PhD. And one of the things that Ruth did as part of her research was to do a small study on courtesy stigma, or the stigma experienced by parents of children with ADHD. And those parents reported that they believed that families had not invited either them or their child around to their homes because of the way in which their child had behaved. So it is certainly a possibility that the children are hearing from parents, or that they are aware from observing the actions of their parents that some children are not welcome in their homes. Louise here is doing work on attribution theory and trying to understand how it is that attribution theory might give us an insight into responses towards young people who've got depression. So Louise's work has generally demonstrated to us that where someone believes that a peer who is depressed is not responsible for their problems, so in other words, where they believe that the problems are outside of their control, they are more likely to have a positive response to them, or a sympathetic response, and to report that they are more socially accepting of them. Now again, as with the other work that we've done, Louise has found that gender is significant. Again, in this case it is that males within her study typically find that, believe that males have more personal control over their depression than they believe females have. Okay, so what are the applications or the implications of this work? Well, firstly, I think all of us who are involved in this really believe that the work we're doing suggests that it is really important to focus within mental health research not just on the kinds of difficulties that young people with mental health problems themselves are facing, not just to look at them and their families alone, because of course their behaviour is manifest within a much wider context, and within that context it's going to be important to understand how other people react to them. That probably will mean getting involved in the development of things like interventions to try to promote a better understanding of mental health, and it will, hopefully our research would contribute to the development of age and gender appropriate interventions, because our work certainly suggests that males and females have different responses and children of different ages have different responses. Those kinds of differences will need to be taken into account when developing interventions. I also think it's important to simply highlight for parents, for teachers, and for the therapists or the young people themselves that other people with mental health problems do have experienced these difficulties, that may in and of itself help them to deal with them, or at least alert them to the kinds of issues that might arise. So our plans at the moment are to try to use Bigler and Lieben's model, the developmental intergroup theory, in order to inform where we would go next. So for example, we're very interested in the way in which children might learn negative responses, so perhaps trying to understand whether there is correspondence between parental beliefs about mental health and young people or children's beliefs about mental health. Also within classrooms, are there correspondences between young people's response to peers with mental health problems and the teacher's response? We're interested in looking at essentialism, or the belief that certain characteristics are likely to go together, perhaps the belief that someone with ADHD is not as going to be able to perform as well in class as somebody else. So where and how those beliefs are likely to be influencing responses to young people. And then perhaps arising more from the kind of work that Lynn has done, in which she's actually identified and spoken to young people who actually have mental health problems. We're looking at the potential that young people with mental health problems believe that they themselves form an in-group. Now this is quite an interesting thing. It's quite widespread in the adult mental health stigma literature, the idea that people who have mental health problems believe that they have an in-group with other people who've got mental health problems. And at the moment it looks as if we may have some significance that, or some beliefs there, that people with mental health problems see themselves as slightly different from their peer group, and that they believe that they can fit in with other children who are different. It may not be that they are identifying this as linked into a mental health problem, but certainly that they may be trying to find a group that they believe are separate and different from the mainstream group. And there I'd like to say thank you and invite you to ask any questions.